Hello, today we're going to be talking about eating disorders. As you are probably already aware, sociocultural factors contribute to the development of eating disorders probably more than for any other disorder. In Western culture, including in the United States, we have this feminine, thin ideal about beauty. It comes from various sources: the media, advertising, the clothing industry, where girls get the message that you have to be thin in order to be beautiful. Just when an adolescent girl is moving into puberty and her body is starting to develop and move away from the thin ideal, she is confronted with this unfortunate bias about beauty. Of course, girls are exposed to it even before at an earlier time in their lives. Just think about the traditional Barbie doll. Some girls who are vulnerable for other reasons may be susceptible to developing eating disorders during this tender time in their lives as they move into adolescence. As you know, eating disorders occur much more often in females than males, and the age of onset is usually in early adolescence for anorexia nervosa, and a little bit later on in adolescence into early adulthood for bulimia nervosa. While these disorders are not nearly as common as some of the others we have discussed, such as anxiety disorders and mood disorders, we do tend to hear a fair amount about them, especially when high-profile people deal with eating disorders and we see publicity about their struggle. An example of this would be Princess Diana, who went public about her struggles with bulimia before her death. And as a result, probably many people were more willing then to acknowledge their struggles and hopefully to get help for themselves after she took that step. As I'm sure you are aware, in the case of anorexia nervosa, the individual will starve themselves, sometimes to death, if they are not stopped. They have this distorted belief that they are too big. When they look in the mirror, they see a bigger person looking back at them. So, in other words, they have a distorted body image. And they have an unusual relationship with food and eating. Interestingly, some people with anorexia nervosa will hoard food or be obsessed with food, will cook food, but they just don't eat it or very little of it. Anorexia nervosa also carries with it various health risks, as I'm sure you are already aware. Sadly, anorexia nervosa has the highest mortality rate of all psychological disorders. What would you guess are the reasons why this is so? Well, one of the reasons is because of cardiac problems that can result from starvation, including weakening of the heart and causing electrolyte imbalances in the body that can trigger a heart attack. And the second reason is suicide. So it's a very serious disorder, one we need to take seriously and do everything we can to help someone with this disorder to get the help she or he needs. Often the individual with anorexia nervosa thinks that the rest of us are misinformed and we are the ones with the problem, and that the person with anorexia nervosa just needs to be left alone. Interestingly, she does feel in control because she is succeeding at starving herself. Some other interesting features of anorexia nervosa include what's called the development of lanugo, or fine baby hair, all over the body, and the cessation of menstruation, called amenorrhea, that can result after a certain amount of weight loss. In the case of bulimia nervosa, there are some similarities to anorexia nervosa and also some differences. Interestingly, in both of these disorders, oftentimes the disorder will start after an unsuccessful attempt at dieting. But in the case of bulimia, while there is also a distorted body image, the person's weight usually is within 10% of normal weight, up or down. Of course, in the case of bulimia nervosa, what the pattern that we typically associate with it is one of binging and purging. Binging usually involves high calorie, low nutrition foods like ice cream and peanuts and potato chips and cookies and other kind of things like that the person eats in large quantities, sometimes consuming many thousands of calories in one sitting. And then the individual purges after that to get rid of some of those calories. As it turns out, purging is not a very successful way of getting rid of those calories, but individuals do it anyway. So what's going on there? The person typically has psychological and physical sense of discomfort in their body, maybe an empty feeling or a tense or nervous or uptight feeling that they relieve through their binging behavior. They fill themselves, but they go beyond that. They gorge themselves and they don't like the way that feels. And then they engage in the purging type of activity. Oftentimes, of course, they're causing themselves to throw up, but they may use other purging methods as well, including things like diuretics and laxatives. One common physical complication associated with bulimia nervosa is the effect that continuous throwing up has on the stomach, the esophagus, the mouth, the teeth of the person who does it, because of the caustic effect the gastric acid has on their body. A good example of that would be dental problems that individuals with bulimia nervosa might experience. So that's a bit of an overview of some of the characteristics of individuals with anorexia nervosa and bulimia nervosa. I'd like to talk with you about a couple of interesting ideas in our book about factors that might be associated with the development of those disorders. The psychodynamic theorist Hilda Bruck has a very interesting theory that does have some research support, as you'll note when you read about it. Her idea is that when children are young, in some families, the parents have difficulty differentiating the child's needs and responding appropriately to those needs. So the parent may turn to food in inappropriate situations to calm or soothe the child. Then, as the child grows up, they too have difficulty differentiating their different needs and learning the most appropriate ways to respond to them so that they may turn to food in inappropriate ways to comfort themselves, deal with stress, and that sort of thing. Another interesting notion about eating disorders in terms of looking at factors that may contribute to the cause of them comes from a sociocultural position of looking at what's going on in the families of individuals with eating disorders. And the well-known family therapist Salvador Minuchin has this idea that in families where there are eating disorders, oftentimes you find what's called enmeshment in the families. Families that are enmeshed, they care about one another, but they are over-involved with each other, and there aren't really healthy boundaries about thoughts and feelings and privacy and that sort of thing in those families. So those are a couple of interesting notions that you'll read about in your Comer text that help us to understand some of the factors that might give rise to the development of eating disorders. Also wanted to bring your attention to the fascinating study that was done in the Southwest Pacific islands, where they went in and studied a community where before and after they had access to American television. You actually have a video on this that you can watch where the lead researcher, Becker, is interviewed. So in this one community in the Fiji Islands, they found that prior to the introduction of American television, the view of beauty was that a full-figured woman was a beautiful woman. And there were hardly any cases of eating disorders. Then with the introduction of American television shows in the 1990s, they saw a significant increase in the prevalence of eating disorders in that area. They believe that this increase resulted from exposure to Western ideas about feminine beauty, that feminine thin ideal that we were talking about previously. Another way that we can think about the development of eating disorders and maintaining an eating disorder is from the perspective of behavioral theory. And we can combine cognitive and behavioral theory together as yet another way of understanding the way in which individuals with eating disorders come to think in an unrealistic way about their bodies and food. But looking at eating disorders from a behavioral perspective, one way that we can think about bulimia in particular is in terms of operant conditioning theory. If you recall from learning about operant conditioning theory, there are two kinds of reinforcement: positive reinforcement and negative reinforcement. In positive reinforcement, some pleasant event follows an action, and we're then more likely to engage in that action in the future because it was followed by a pleasant event, some sort of reward or positive reinforcement. In the case of negative reinforcement, something unpleasant is already occurring, and we do something to make that unpleasant thing stop. We will then be more likely to engage in whatever action made that unpleasant thing stop in the future. So think for a moment about how you might apply these principles of positive and negative reinforcement to the binge purge cycle of individuals who are struggling with bulimia. As we were suggesting earlier, when someone is bulimic, their binge purge cycle is often preceded by some sort of uncomfortable, unpleasant, uh, emotional and physical sensations, experiences going on in their body, where they turn to food to ease these uncomfortable sensations or feelings. And when they turn to food, that's when they binge eat. So the unpleasant, uncomfortable state of their body prior to binging is eliminated or at least relieved through the binging behavior. And that would be an example of negative reinforcement. Something unpleasant is happening. You do something to make that unpleasant thing stop, you'll be more likely to do it in the future. Unfortunately, it's sort of a double whammy for somebody with bulimia, because then when they gorge themselves, they don't necessarily like how that feels either. And they may be concerned about all those calories. So then they make themselves purge in order to relieve that uncomfortable feeling, seeing negative reinforcement occurring again. And this pattern, of course, repeats itself over and over again, and often increases in frequency, of course, as it gets worse. Something else of interest to consider about bulimia nervosa is how secretive individuals are who develop this disorder. You could have a family member or a close friend who's bulimic and not even know it, because they're so skilled at keeping it from everyone around them. So let's talk a little bit about the treatment of eating disorders, both anorexia nervosa and bulimia nervosa. I hope by now we all appreciate the seriousness of both of these disorders and why it would be so important to help someone struggling with anorexia or bulimia to receive skilled help from highly trained professionals who usually, or often at least, work as a team in order to help individuals with eating disorders. I'll say that if I had someone in my family with an eating disorder, if at all possible, I would like to see them start out at a specialized uh, treatment program where they could have a team approach to assessment and treatment, so that they would have a greater likelihood, hopefully, of getting the help that they needed and would be more likely to get to a better place in terms of their recovery. Anorexia nervosa treatment oftentimes needs to start in a hospital, where medical intervention may be the first thing that needs to occur, because the individual needs to become stabilized medically, physically, and to start, gaining weight so that they're not in physical danger before you can really begin to work on the psychological issues that are involved. Our textbook does a nice job of describing the way of approaching the treatment of both of these disorders. And you'll note that anorexia nervosa treatment often starts in the hospital. The focus is taken off of weight per se and placed on helping the person get to a healthier place in terms of both their physical and psychological functioning. And then it's possible to work on individual issues and family issues that need to be addressed as a part of the therapy. In the case of bulimia nervosa, sometimes that treatment also starts in an inpatient setting and sometimes in an outpatient setting. The outpatient part might be intensive at first, meaning that the person meets several hours during the week, and then it would gradually taper off until eventually they would have outpatient follow-up sessions, either at that treatment center or with someone in their local community who could coordinate with that treatment center. There again, in your textbook, there's a good discussion about some of the more specific details of the treatment of bulimia nervosa. One point I would like to make, though, is that with both of these disorders, there is increased risk for relapse. So attending to relapse prevention as an important phase of the treatment is really important. And especially identifying stressors that could trigger relapse and helping the individual to address those stressors so that they would be less likely to trip them up and cause them to slide back once they finish the treatment program. Well, I think that's about it for now, and I look forward to talking with you again soon.